region or the nasolabial fold. You don't need to be up near the eye. It can cause retinal artery occlusion. Angiogenic ophthalmic artery occlusion is associated with painful blindness. And this is again from the Korean literature. So it certainly can happen with hypodermic needles. That piece of Korean literature is not common to have microcannulus. Now, disadvantages of microcannula use. Well, there's a little bit of an incremental increased cost, which I think is irrelevant in terms of good care for your patient. And I mean, if your patients are happier, we all understand. If your patients are happier, it's good for everybody. There's a learning curve. This flexibility business. Some people like that flexibility. Others are like, I mean, surely it's better to have a linear determination or approximation of where the tip of your needle is. If this thing's squiggling around, well, you can make your own determination in that. But again, there are different brands, and some are more rigid than others, and I think you can find something that fits your desires quite nicely. The filler material, as I mentioned, doesn't come out of the tip, so you've got to have a mental picture of where your filler is actually emerging. It's a bit different than with hypodermic needles. And also, I've found, when you're poking through some of the slightly tougher planes, when you're doing, let's say, the tear trough and you want to go deep, the orbicularis, sometimes it slides in there beautifully. Sometimes not so much. And I'm having to sort of poke and kind of gently pass through somewhat more robust fascial and tissue planes. And I do think sometimes the patients perceive for a second or so that I'm perhaps even struggling a little bit. This is the reality. But in general, it's not a major issue. Some areas are challenging. Supposing you want to use volatility, you want to go after etched lines or something of this nature, and you really are trying to stay in the dermis to a certain degree, well, perhaps in that circumstance, microcannulas are not as good. I've always also found right up in the alar triangle, right up here next to the nose, I sometimes revert to doing a little bit with hypodermic needles in that area, but almost no other area at this time. All right. Blunt tip, this is simply a visual demonstration of what I think you all intuitively know. You sure wouldn't do that with a sharp needle. That's one of my nurses pressing it into her finger. That's with a blunt tip. There's various brands. There's soft fill. This would be a cannula, a microcannula manufactured where it's a little bit more rigid. You have a little bit more, you could say, control in that respect. I've used them. This is the one that I use more so. It's called Sculptra. I'm in no way beholden or have any relationship with any of these companies. And so that shows the 22 gauge needle that I would use to utilize this 20 gauge microcannula. That's the largest microcannula I would use. You can get a 25 gauge microcannula and many others. Very briefly, there's nothing terribly technical here for you to see. This is me injecting. You can notice, I'm not showing the picture where I inject with local, but you can see there's a little bit of blanched area of skin. I go in with my 20 gauge needle. Again, this is the largest cannula that I would utilize. So it would be clearer for the pictures. There I am making a little port, and here I am injecting. This is preparing to inject some Sculptra fanning technique with a 22 gauge microcannula. Sculptra used to be for me. I mean, I would sometimes get patients you hardly get any bruising. Sometimes, oh my goodness, you get quite substantial bruising. This is a non-event with me. I mean, Sculptra patients just simply don't call up 3 or 4 days later with the same calls they used to make about, my goodness, when's this bruising going on? And so you can see fairly straightforward. This is just a small slide. I won't spend too much time on this, but this is from a very nice Korean article showing a very detailed and sort of emerging better understanding of the anatomy of the tear trough. It's relevant to understand that if you're going with a microcannula, obviously your needle does not just pass effortlessly through any tissue plane. So I think a somewhat more nuanced understanding of the anatomy is helpful when using microcannulas because it's going to brush up against and maybe not penetrate these tissue planes. It's made me think a little bit differently about the anatomy in some areas of the face. Some examples, I think this is just of minor interest because the ultimate clinical result is no different than you would have with needles. So this is a non-surgical rhinoplasty. We've all done these. This is nasolabial folds with, I think this was Perlane. Tear trough injections. So in terms of conclusions, microcannulas appear in my hands to be superior, and pretty plainly so. There is a little bit of an increased cost, but it's modest. I don't think it's worth talking about. I certainly didn't change the price of my services to my patients at all after I adopted these. There's a bit of a learning curve, but it's terribly doable. Think of all the things we've discussed in this meeting that we know are multi-year learning curves. advanced facelifting. This is well within the quiver that we can develop. Penetration of microcannulas, as many of us know, is far, far higher in the European Union than it is in the United States. And I've been curious as to why. If you go over there, it's not that everybody's using them, but you've noticed they're all manufactured there. I think there's a different attitude there. And I'm a little surprised that adoption is many years this has been available to all of us, and most of us are still using hypodermic needles. A parallel shift with needles took place with fat injections. Perhaps some of the providers here who were practicing before I did can comment on this. But the best as I understand it, when autologous fat transfer emerged, sort of in the 90s and what have you, there was tons of people using hypodermic needles. And what was a very significant and common complication? Fat embolism into vessels, and significant, in some cases, cataclysmic complications for patients. And so what do we all do? Well, any of you in our ORs, what do you have there? You have your tulip microcannula injection set. And best as I know, I've heard wonderful presentations all throughout this meeting about fat transfer. There's very little comment on that complication. Largely went away. Is there a different underlying conceptual framework here? I don't know. I don't think so. Any case, so why the slow pace of adoption? I mean, I'll leave that to all of you to think about. I'd love to field any questions about this. In terms of those few comments I wanted to make, I guess, in terms of transparency of consent, my goodness. I mean, if you're going to do a lower BLEF, we know it's a rare event. How many of you take a patient DR for a lower BLEF and don't mention the B word? I think this is a relatively rare event, but we just heard that, wow, when you really get set up a little bit of a system to a little bit of a finer net to catch all these events, you start to reveal something a little bit scary. And so, every patient, not just written on the consent, and not just intravascular events is on the consent. The B word with every filler patient is on the consent and passes through my lips into their ears. Every single patient, every single time that I have somebody come in for just routine Juvederm to the nasolabial fold. In my view, I mean, if that were my family member, that's so thank you very much. Paul?
How quickly do you inject with the needles in terms of volume minus and so on?
And so certainly, well, I don't use needles very much. Do you mean with the microcannulas?
Less pressure, so on.
Certainly, I think that's sort of considered sort of universal good technique. It is important to point out that it's not that you can't get into a vessel with a blood tip microcannula. I use 30 gauge blood tip microcannulas. It's a pretty fine thing. You wouldn't want to press that real hard against your finger. It certainly would hurt. And so we always tell patients this. This dramatically reduces the likelihood, we think, that we await emerging data to give you tremendous clarity on this. But we certainly think it's logical, it's much less likely. But yes, Dr. Keller, you could get into that vessel, at which case, again, all of the standard precautionary things should you inject as you're pulling out, though we've heard different opinions on that in this meeting. Should you inject slowly? I certainly think so. Because you can never say never in medicine, and therefore layers of precaution as opposed to just, well, shoot, I'm using microcannula, let's get crazy. No, that's not the perspective. Sir, thank you.